Welcome to Podcasts for Patients. My name is Lee Clark, Senior Director of Patient Programs at the Aplastic Anemia and MDS International Foundation. Before we get started with our podcast, I'd like to thank our Diamond Level sponsors, Alexion, Apellis, Gamedicel, and Novartis, who without their support, this podcast would not be possible. I have the pleasure today of speaking with Dr. Salhotra, who is a hematologist-oncologist and a professor of medicine at City of Hope National Medical Center in California. He specializes in leukemia, stem cell transplants, and graft versus host disease. It's my pleasure to welcome Dr. Salhotra. Welcome, Dr. Salhotra.
Good morning. Hello.
I'm excited to be able for us to talk about the recent approval. So, what is Tregzi?
Thank you for having me on this podcast. And Tregzi, it's an allogeneic regulatory T-cell based immunotherapy and has both hematopoietic stem cells and T cells packaged as a single product. And it's for use in matched donor setting for patients undergoing an allogeneic stem cell transplantation who are eligible for a myeloablative preparative regimen. In simple terms, what it means is like traditionally how we do stem cell transplants is we go to the donor, we do a peripheral blood apheresis, which is true for 90% of adult patients, and those unmanipulated cells are infused into the recipients after either a myeloablative or a reduced intensity conditioning. We've done it this way for the last 40, 50 years. It's a highly effective technique. The downside of using unmanipulated grafts and pharmacologic prophylaxis has been graft versus host disease. Traditionally with tacrolimus methotrexate or tacrolimus sirolimus based prophylaxis, the incidence of chronic graft versus host disease has been around 50 to 60%, and it does become a debilitating condition in that setting. So what this product has done is basically before infusion of these apheresis peripheral blood stem cells into the patient, there's a separation process where the apheresis graft is separated into CD34 positive stem cells and regulatory T cells, which are infused on day 0. And around 48 hours later, the patient receives conventional T cells. Splitting this product into 2 separate infusions allows for a smoother transplant process. And the greatest gains have been in the incidence of reduction of graft versus host disease. And we'll talk about the clinical trial data as well. But essentially, it's an ex vivo manipulated graft to reduce the incidence of chronic GVHD and to reduce the non-relapse mortality, which are kind of linked to a stem cell transplant procedure.
Thank you for mentioning the clinical trial and the data. Are there some things that you can tell us about the trial and what led to the approval?
Yes, the clinical trial that led to approval of Tregzi was the Precision 3 trial, which is a randomized multi-center phase 3 study. And essentially, approximately 190 patients were enrolled on the study. And for patients to be eligible for enrollment, they should have been eligible for a myeloablative conditioning, either radiation-based or chemotherapy-based. They should have a diagnosis of acute leukemia or MDS. And there should have been eligible donor. Eligible donor would be a fully matched sibling donor or a fully matched unrelated donor within the continental United States. So once the patient met their criteria for allogeneic transplant from a recipient and a donor standpoint, patients underwent randomization to the experimental arm where they received ORCA-T graft in a way that I just mentioned to you. So they received their standard myeloablative conditioning followed by, instead of pharmacological prophylaxis, they received ORCA-T and single agent prophylaxis with tacrolimus. And we compared it to our current standard of care treatment, which is myeloablative conditioning followed by tacrolimus and methotrexate-based conditioning and GVHD prophylaxis. And methotrexate was at the standard 45 milligram per meter square. So the primary outcome was the incidence of chronic GVHD-free survival at 1 year, and there were multiple secondary endpoints, including overall survival, relapse-free survival, incidence of acute and chronic GVHD, and a non-relapse mortality.
How does Tregzi change transplant for patients and their donors?
That's a good question, Lee. There are some workflow differences which the patients and the transplant centers have to be mindful of when undergoing an allogeneic transplant with Tregzi. And the changes on the recipient side is that there are some limitations in terms of the donor availability. It has to be a fully matched sibling donor. And if it's an unrelated donor, it has to be within the continental United States. And that's just related to the manufacturing of the graft, which is done at the Orca Bio facility up in Sacramento. So that limits the international donors to some extent. Now, we've been able to use donors in Mexico and Canada. So North American unrelated donors should still be okay. But most of the donors from Europe, currently, they cannot participate in this study. In terms of the collection, most of the donors were able to collect the standard apheresis graft in a day or two, so it does not change a lot in terms of the collection of the stem cells on the donor end. On the recipient side of things actually are pretty much similar to what we do for our standard of care patients. They receive their myeloablative conditioning. It could either be a radiation-based or chemotherapy-based conditioning, but the bulk of the changes are at the side of the donor in terms of collection. On the recipient side, of course, with the GVHD prophylaxis with the use of ORCA-T, there is a split dosing which is given. So on day 0, patients receive their ORCA-T graft, which comprises of stem cells and regulatory T cells. And of course, they have to be infused fresh. And around 24 to 48 hours later, they can receive their cryopreserved bag of conventional T cells. And then after they receive their conventional T cells, then they get their single agent prophylaxis with tacrolimus. If you allow me a moment, I'll just try to explain the strategy as to why the split dosing is done. So the CD34 cells, of course, reconstitute their long-term hematopoiesis, leads to eventual formation of all your blood cells and the immune components. But the regulatory T cells, which are infused on day 0, they undergo in vivo expansion. They inhibit the alloreactive conventional T cells, which are infused a couple of days later. And the ratio of regulatory T cells and conventional T cells, it's kept at 1:1, which is slightly different than what happens in an unmanipulated graft. And this equalization of the regulatory and the conventional T cells, this allows the graft to significantly reduce the incidence of chronic graft versus host disease. In some of the prior studies where we've tried to use CD34 selected grafts, since they were not infused with T cells, the incidence of infections and non-relapse mortality was low. But infusion of the T-cons on day 2 prevents some of the infectious complications, as talk a little bit about the readouts and the study data. So this strategy of splitting the doses of regulatory T cells and conventional T cells significantly reduces GVHD while preserving the graft versus infection immunity. The 1-year overall survival in ORCA-T was approximately 94% compared to 83% in the TAC methotrexate arm. So although there was no significant difference, but patients who were on the ORCA-T arm, they tended to have better overall survival compared to TAC methotrexate arm. Looking at the incidence of moderate to severe chronic GVHD, the true incidence was approximately 44% in the standard of care arm versus 12.6% in the ORCA-T arm. So the study met all its primary endpoints of better chronic GVHD survival, lower incidence of chronic GVHD, and non-significant improvement in overall survival. So overall, the study met its primary endpoint of lower chronic GVHD-free survival without any increase in relapse rate and a trend towards improvement in overall survival at the 1-year mark. It'll be important to see how patients do at long-term follow-up at 2 and 3 years, and if we see a separation of curves with longer duration of follow-up.
What are the known side effects?
A few pointers regarding the safety of this drug. So there were side effects as we would anticipate in any transplant study. So the incidence of serious treatment emergent adverse events was approximately 40% in the ORCA-T arm and approximately 56% in the standard of care arm, which was tacrolimus and methotrexate. When we looked at the number of rehospitalizations, patients admitted to the ICU, they were significantly lower in the ORCA-T arm. Number of rehospitalizations were also lower. When we look at the relapse-free survival, that was similar across both groups. Non-relapse mortality was significantly lower, and the incidence of grade 3 infections was again significantly lower in favor of the ORCA-T arm compared to the standard of care arm. In terms of safety, well, yeah, I would say that the infusion was well tolerated. And when we talk about safety of an allogeneic product, we're looking at the incidence of infections, incidence of acute and chronic GVHD. And at least on those measures, the ORCA-T graft scored significantly better compared to the tacrolimus and methotrexate arms. Then you worry about infusional reactions or manufacturing failures. All of the donors in which the product was collected, they were able to successfully manufacture the ORCA-T graft. It was able to meet specifications in majority of the cases. There was no case of graft failure, primary graft failure in patients who received the graft. So the product was safe from an infection standpoint, from non-relapse mortality, and from manufacturing standpoint.
What else would you like patients to know about this new approval?
Thank you for that question. So yeah, so the main take-home message is that it's a newer way to do stem cell transplants, and the infusion of this graft is definitely associated with lower incidence of chronic GVHD, low rates of infections, and potentially a trend towards improvement in overall survival. Patients need to be eligible for a myeloablative conditioning regimen. So they need to receive either a FTBI-based, radiation-based, or chemotherapy-based myeloablative regimen. And as long as they have an eligible donor, they would be eligible for this novel stem cell product. And it does a good job in terms of reducing chronic GVHD. One of the things that I've heard from my colleagues is how does it compare to post-transplant cyclophosphamide, which is up and coming and has shown a reduction in chronic GVHD. So those are two of the dominant platforms to reduce GVHD. I would say ORCA-T, it's more established on the myeloablative side, and on the reduced intensity side, post-transplant cyclophosphamide is a good approach to reduce GVHD. So in the next few years, it'll be more clear as to which patient populations would benefit from post-transplant cyclophosphamide, which patients' populations would benefit from an ORCA-T graft. But our patients now have the option of two very effective strategies to reduce incidence of GVHD.
Well, thank you so much, Dr. Salhotra, for spending your time and your expertise with us today and letting all of us know about the new approval of Tregzi. If you're interested in finding out more information about stem cell transplant, please feel free to find information on our website, which is aamds.org, or you can give the foundation a call at 301-279-7202, and we're happy to answer all of your questions. Thank you for joining us.
Thank you.